All right. Good afternoon, everybody. My name is Jessica Cecil. I'm the Education Coordinator at the National Aging Research Institute. Welcome to our online Seminars in Aging program. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today. For me, that is the Wurrung people, and pay my respects to their elders, past, present, and emerging. A little bit of housekeeping regarding Zoom. At the conclusion of the talk, we'll have some time for Q&A. If you have any questions, you could submit them throughout the seminar using the chat function, which can be opened using the chat tab at the bottom of the screen. So today we're going to be hearing from Professor Li-Fei Lau, and Alex is going to be introducing her. Welcome, Alex.
Thank you, Jessica. So good afternoon, everyone. I'm Alex Bahar-Fuchs, and I'm a Principal Research Fellow in the Academic Unit for Psychiatry of Old Age, as well as a neuropsychologist in private practice, primarily working with people with mild dementia. And it is my pleasure to introduce today's speaker, as Jessica said, who comes to us virtually all the way from the University of Sydney, Professor Li-Fei Lau. I have known Professor Li-Fei for a number of years now, and I've had the pleasure of engaging with her when she led the then NNIDR Rehabilitation in Dementia group, and when she then invited me to contribute a chapter to the dementia rehabilitation book that she co-edited with Professor Kate Laver from Flinders University a couple of years ago. I must say, I've always found working alongside Li-Fei kind of inspiring with her enthusiasm and passion for everything to do with dementia rehabilitation. So I am very, very happy that she agreed to come and talk to us today after having a very, very busy week last week at the Australian Dementia Research Forum. So a little bit about Li-Fei. She's a professor in aging and health at the University of Sydney and a registered psychologist with a PhD in psychiatric epidemiology. Professor Lau conducts research that she hopes, well, I can say that makes a difference in the world. Her main areas of expertise are in rehabilitation and post-diagnostic support for people with dementia, home and residential care for older people, the impact of COVID-19 on people with dementia, stigma and dementia literacy, as well as people from culturally and linguistically diverse backgrounds. She is particularly interested in developing and evaluating interventions to improve the quality of life of older people. She has methodological skills.
That'll do, Alex.
I'm nearly there.
No, stop.
No, you're being very humble. She's got a range of very impressive methodological skills. She's authored over 130 research papers, as well as 3 books on dementia. The bit that I like the most, and I'll skip to the end, is that she thinks that research is a great fun and even admits to liking statistics.
Thanks, Alex.
All right. Well,
thanks for the kind introduction. And thanks everyone for coming. I'm sorry to not be in person at NARI. I was hoping to be there this week, but I couldn't come this week. So I'm very happy to present at this. If you were at the Australian Dementia Research Forum last week, I did present some of these slides, but I have recooked them for you this week, and I'm going to give you some behind the scenes commentary as well around some of the methods that we've been using in this research. So acknowledging that most of this work is from the Cognizance study, and it's a big team. It's not just me. So to start with, oh, there's a lot of people here and I can't see you. It's kind of sad. I want you to chat to me. So when you see and hear the word dementia, what comes to mind? What things come to mind? Just share with me in the chat your thoughts, your initial thoughts. Cognitive decline, confusion, memory loss, Alzheimer's disease, sadness, stigma, change in life, changes to thinking skills, forgetfulness. Thank you. Keep going, guys. Thoughts, feelings, old people, changes to personality, stigma, changes to movement, can't do things, can't pay bills, incontinence. Range of symptoms, including changes to thinking, planning, living, family freaking out, feelings of redundancy, changed life views, sadness, discrimination, loss of social connectedness. Yep. Family stress, loss of identity, change of priorities, loss of independence. Yes, yep. Isolation. Many medical appointments. Yes, absolutely. Opportunities. Thank you, Anita. That's an interesting one. We'll talk about that. Confusion. So thank you for chatting to me. It makes me feel less lonely up here by myself. Advocacy. So when we talk to people about what they think and feel about dementia, we get many of the similar responses to what you've told us about. And we've done this exercise with lots of people with dementia and carers and health and aged care professionals. We usually get a lot of information about, some information about cognitive symptoms. We get information about functional symptoms. We get information about losses, and we sometimes get information about kind of the logistics of navigating the medical system, very similar to the things that you have said. And as kind of the theme in the chat today, a lot of the language around dementia is negative, and that's, you know, the experience, I think, of many people with dementia. And if we think of cancer, I think it was similar for cancer 20 or 30 years ago. I remember I had a cousin and she died of cancer, and we didn't know she had cancer before she died because it was so stigmatized in the Chinese community that the family didn't know. And while things are slowly changing with dementia, I think there's still a lot of way to go about that. So, whoop, 2 slides. Often someone will tell us that dementia is a brain disease. And when we used to give talks about dementia, I would just show brain pictures. And sometimes if you Google dementia, you also get this kind of disintegration picture of dementia, this loss of identity and memory. And I want us to just shift our thinking to that word that I think Anita threw into the chat about opportunities, and that dementia doesn't have to be overwhelmingly negative. So in the early 2010s, we were doing research about people with dementia, but not with people with dementia. Here's a study that we published in 2013, 2011, can't remember when it was published. But in this study, people with dementia were study participants. We definitely didn't co-design people with dementia. And the majority of data that we actually got from people with dementia was not by asking them. We actually asked their family member or a staff member, or we observed them. And we didn't really have the voice of people with dementia in our research. There were very few valid interview tools with people with dementia. In this study, we used the DemQual, which we found really problematic in terms of getting the views of people with dementia with. And people with dementia almost never were asked to self-complete a questionnaire, which is different to, I think, how we're operating now. So a lot of the research we did was to help carers help people with dementia. So one of the seminal studies was the Prince Henry Hospital Dementia Carers Program, which Henry Brodati and Meredith Gresham, who I still work with, who I work with these days, did in the 90s. And I was very strongly influenced by Kate Swaffer, who I think many of you will know, when she talked about prescribed disengagement. She said that when she got diagnosed with dementia, her neurologist told her to give up work, give up study, get your end of life affairs in order, and get acquainted with aged care. The suggestion that she should be reducing activities. Sorry, just back to Kate. And I listened to Kate's story, and I kind of wondered what we could do about this. And people with dementia and carers will say that things haven't changed since 2015. And perhaps for the majority of people with dementia in Australia, things haven't changed, but there are slow pockets of change. There are services around the shops, such as the one at War Memorial Hospital here in Sydney, which are offering rehabilitation for people with dementia. And I think there is groundswell and momentum to get more rehabilitation and more post-diagnostic support for people with dementia. And that's really important because at the same time as we were doing, our research on people with dementia and doing carers projects, our colleagues who are looking at early dementia were, shifting from doing studies on MCI to really very early pre-dementias. And the technologies and I guess the research thinking around detecting dementia early and earlier is kind of happening. And while we don't have good data on this, I suspect that even in Australia, some people are getting diagnosed earlier, which means we have more people who would benefit from rehab who aren't getting these services. And so there's a big gap between when you're diagnosed and when you qualify for aged care, which is kind of the, I guess, traditionally the services that you got for dementia. So let's talk about what post-diagnostic support is. And I don't think it's just cognitive training, though cognitive training is very valuable, and you've got an expert in this team about it in the form of Alex Bahar-Fuchs. And it's not just carer support and carer psychoeducation, like even though there's pretty good evidence, there is good evidence for this, and these programs have been rolled out around Australia now. So if we just step back and think about dementia and the criteria for diagnosing dementia, there's all these cognitive impairments, which is why I think we've been very driven to develop cognitive-based interventions for people with dementia, because the cognitive deficits are so apparent in how we think about dementia. And certainly cognition is the most frequent primary outcome of trials for people with dementia, both drug trials, but also rehab trials until recently. But we haven't given as much focus, I think, that cognitive deficits interfere with independence and daily activities, and that functional impairment is one of the major symptoms of dementia that we don't seem to be intervening as enthusiastically in terms with function. So this story is from the Daily Mail. I was quite taken by the story of this lady who basically designed her own rehabilitative strategies. And I've seen other people with dementia now who have these strategies. So she's got her own series of post-it notes, and she's got pictures outside her kitchen drawers so that she knows what's inside each cupboard, which is her own kind of designed rehabilitation. And if you had an occupational therapist, they might help you kind of set up these strategies. But these were the problems that, this is the problem that her dementia was causing her, not necessarily the memory impairment, but the functional impairment caused by her memory impairment. Another major source of stress, I guess, that people with dementia and carers tell us about is not being able to drive anymore, and transport, functional mobility, and being able to get about in the world is a major issue that we need to solve, I think, for people with dementia. And we know, and in the chat you told me that dementia also comes with social isolation, stigma, loneliness, not knowing where you fit in society or who you are in society anymore. And I think importantly, dementia also changes our relationships with our healthcare providers. We've heard lots of stories now where the person with dementia says, well, and once I got the diagnosis, the doctor turned and spoke to my carer and didn't speak to me anymore, even though I was still there. And it's not just stigma, but I think the ability for people with dementia to play an active role in decision making, we need to think about that as part of rehabilitation as well. So I think that traditionally, I, as a psychologist as well, I've had a very cognitive model of dementia. So I think of dementia as a problem with the brain, a problem with cognition, and what we need to do is we need to improve the brain and practice and fix the cognition. And in thinking about rehabilitation, I think I've been much more shifting our thoughts towards a psychosocial model of dementia, that dementia isn't just about the brain. It is about function, and it's about how the person functions in their environment, which could be their home environment, so the stuff that occupational therapists deal with, or their community environment, which occupational therapists might also help with, but also in society, and that people with dementia are disabled socially, if that makes sense. So I guess we've been challenging kind of reframing of post-diagnostic support to move beyond thinking about cognition and brain health, though these things are important, to thinking about post-diagnostic support as supporting someone's function, daily function, but also overall well-being, and kind of considering their social environment as part of that conceptualization of dementia. And I've been explicitly saying that post-diagnostic support needs to include rehabilitation and support, especially if we take this very broad view of what rehabilitation is. So this is the WHO definition of rehabilitation, which is that rehab is a set of measures that assists individuals who experience or are likely to experience disability, which is what people with dementia are. That's the situation people with dementia are in, to achieve and maintain optimum functioning in interaction with their environments. So I'll just read it again. Rehab is a set of measures that assists individuals who experience or are likely to experience disability to achieve and maintain optimum functioning in interaction with their environments. So this is a very broad view of rehab. I know that in Australia, we tend to think of rehabilitation as something that happens kind of post-hospital, and have a very physical kind of idea of what rehab is, acute and physical kind of treatments. But if we think of rehab in this broader view, which will also include concepts such as reablement and restorative care, that, you know, it's easier to kind of fit the idea of post-diagnostic support as also including rehab for people with dementia. So the aims of rehab, as per WHO, are to prevent the loss of function, slow the rate of loss of function, improve or restore function, compensate for lost function, maintain current function. And as Alex already mentioned, we collated the evidence for rehab in our book. We've got a lovely chapter from Alex on cognitive focused interventions, and there's pretty good evidence for probably up to exercise, and then growing evidence for psychological interventions, and less evidence for peer support, speech pathology, and kind of stigma reducing community interventions such as dementia-friendly communities, which I know have been controversial in Australia as well. So I took out the slides which I was going to present on the details of the evidence for rehab, because I think that I've given that kind of talk quite a few times now. And I kind of want to focus on, I guess, the fact that these services are really hard to find in Australia, that after you get a dementia diagnosis, it's very unusual to be able to find rehab services. Even if they're not called rehab services, we call them occupational therapy or brain training or CST or something else. Which leads us to this project, Cognizance. It's a 5-country study, and our aim was to improve the communication of dementia diagnosis and post-diagnostic support. So Australia is the lead country, but we worked with the UK, Canada, Poland, and the Netherlands. And I'm going to sidebar for a minute and just talk about, I guess, the benefits and the challenges in trying to do a study across these 5 countries. We met once together in The Hague, and that was great. And I think that this group has really brought a collective action and momentum to our work. You know, there's more people who also care about the thing that you care about improving, and it's a problem in their country as well, and you can learn from them. We've also had many experts from different backgrounds. So we've got you know, nurses, GPs, people who are from social workers, doctors, psychiatrists, and we've come from different, I guess, departments and spheres. Oh, we've got OTs, psychologists, public health people as well. And so we've learned from each other, but there've been huge differences in our systems and ways of working. So huge differences in the health and aged care and dementia diagnostic systems. So I think Australia sits in the middle, where things are really bad in Poland, and things that we could, you know, we try and do in Australia make no sense in Poland because they have don't have those services, and things being probably better supported in the Netherlands, for example. They have case managers for people with dementia. And so I think that the challenge in thinking about post-diagnostic support is that some countries have so little and some countries have more, and how can we kind of learn from those things but build something common across those countries as well. And also the teams have different ways of working with each other, and we had to kind of learn a new norm of how to work together. And for those of you wanting to do big international collaborations, it is not easy trying to get this many people to work across 3 different time zones together, and it led to Australians always, you know, getting up really early or having meetings late at night. I think across this big team, we also had dispersion of responsibility. So sometimes Australia is the lead country, but there's a team, you know, leading evaluation or leading website development or leading survey development. And it wasn't clear then who was the boss, or sometimes there were too many bosses and we couldn't agree on stuff. So that was really challenging, I think, part of this project as well. And like many other studies, we were majorly disrupted by COVID. And yeah, I guess I'm proud that we did something, and we managed to co-design something with people with dementia, using kind of online options only, really, through this study. So now I've sidebarred, I'm going to go back to telling you a bit more about this project. These are just the Australian data. So this is the formative research from the Cognizant study, where we were surveying and talking to people with dementia, carers, and health and social care practitioners about the current state of post-diagnostic support for people with dementia. So I'm going to show you the highlights of some of the findings. This shows the post-diagnostic experiences of just the Australians. Relative to the other countries, Australians were basically less satisfied with the post-diagnostic supports that they got. So less than half of participants received a care plan or sufficient information about managing their dementia after diagnosis. And less than a third were confident about asking for professional help or living confidently with dementia. So less than a fifth of clinicians said that they often or always provide a care plan after diagnosis. Just over a third were satisfied with linkages to post-diagnostic services, and just over half were satisfied with post-diagnostic supports in their region. Though, interestingly, over 70% said that they had received adequate training in post-diagnostic supports. I've already presented these data quite a few times. So I'm just going to quickly go through it and say that from our Australian data in particular, people with dementia carers said that they had very strong emotional reactions after getting the dementia diagnosis, that it was devastating, that there was shock and confusion, grief and loss, fear, anxiety, worry. So many of those negative words that you put in the chat today. And for many of them, there was disbelief, uncertainty, denial, and for some of them, they actually felt relief because they had an explanation for the symptoms. I think what really struck us was that almost no one got very good support after diagnosis. And because the diagnosis was so devastating, not getting support made it much worse. It's like people felt like this terrible thing had happened to them and then no one was helping them afterwards. So one person said it was like staring into a void. They felt like they were left to fend for themselves, and many of them said they just really were saying, what do I do now? Interestingly, diagnosticians really found it uncomfortable telling someone they had dementia, and they found even experienced clinicians found it hard. And it was particularly hard for people who were younger than themselves. So people with younger onset dementia, I guess it was really confronting to have to tell someone similar to them, younger than them, that they had dementia. And the clinicians we talked to who were a very biased group of clinicians who were very interested in dementia and passionate about dementia, who agreed to talk to us. They stressed how important follow-up and a positive narrative is. And the clinicians also talked about the system really being a challenge, that CADMS clinics, for example, there in Victoria where you are, they really were telling us that they have no funding and they're not meant to do post-diagnostic support. Your CADMS clinics are just funded to deliver diagnosis. And certainly other memory clinics and specialists also kind of talked about the system being really difficult. Many clinicians talked about wanting a key worker to navigate and coordinate information and services after diagnosis. And we noticed really, I guess, two disconnects. Firstly, that there was a disconnect between who gave the diagnosis and who delivered post-diagnostic services. So in Australia, we have some good post-diagnostic services funded federally and delivered by Dementia Australia. But the person giving the diagnosis, usually a specialist, a geriatrician, neurologist, or a psychiatrist in memory clinic, and Dementia Australia are, completely different organizations on different systems. And while memory clinics would refer to Dementia Australia, that there was a big gap, I think, and people often didn't take up that offer of post-diagnostic support from Dementia Australia because it wasn't offered in the same place. So this slide shows, I guess, the model of ideal post-diagnostic support that we put together, thinking about all the surveys and interviews that were done here in Australia. And I think key is that there's a whole lot of different services that people with dementia want, which kind of fit into the idea of rehabilitation, though perhaps not all of them do, but that they wanted this one place, a one-stop shop. It could be a physical shop, could be a person. They were talking about a person, but I think a team would have been acceptable, where they got emotional support, information, navigation. They got a plan. It was tailored to time and person, quality, that this person gave them personalized referrals so they didn't have to keep telling their story again. And it gave them local information that they could come back to when something happened and they needed more support. So I guess building on some of this information, we've developed 2 resources to improve post-diagnostic support. These are Forward with Dementia, which hopefully some of you have seen already. I'm going to talk a little bit about how we designed this, and also Dementia Together, which are shared care pathways for people living in the community with dementia. So Forward with Dementia is meant to address this, that there's not much information and hope about dementia, and Dementia Together is kind of looking at the system and how to make the system work better together. So our intervention in Cognizance was a website and campaign. And so we co-designed this with people with dementia, carers, and health and social care practitioners. So this was done in 5 countries, and I'm going to kind of very quickly run you through what we did. So we ran weekly meetings we had weekly meetings. We ran 4 online workshops with people with dementia carers and healthcare professionals in each country. We had to make sure those workshops worked online for people with dementia, which was a big challenge. After each meeting, the team wrote notes and reflections, and then I'm just presenting some of the thematic analysis from those notes today. So in the first workshop, we actually made user journey maps around how people would find information about dementia. So we talked about the motivators for getting help, the objections, for example, stigma, the abilities, so whether you could search a website, whether you had the technology. And we also talked about the triggers, what pushed people to kind of look for information about dementia. We turned these into some messages, and by meeting 2, we actually presented 6 different messages about dementia. I'm not going to go through them all, but you can see that we took these ideas about, what positive messaging about dementia should look like, because that's what people with dementia and carers told us was missing, and that's what healthcare professionals said was really important, this positive message. So we workshopped these across 5 countries, and then we workshopped some brands. You can see we got closer to forward dementia. You can see I guess the thinking and development into what the brand might look like. And then we also workshopped what the website would look like. We ran polls across all the countries to do this. And by meeting 4, we had a final brand and what we thought was a reasonable website structure. And it looks a lot like the website that you can go to, Forward Dementia and look at today. So the campaign brand, people told us, had to instill hope and be positive but realistic. It had to counteract these negative images that you can see I've put on screen, and also had to be really diverse. So they had to have diverse voices and images of people with dementia. We had very interesting conversations about how old the people should look in the images. There wasn't agreement. Sometimes they said, oh, they look too old. Sometimes they said they look too young. But it was really important, I think, particularly for our Australian audience, but in other countries, that there was a diverse kind of voice and image of people with dementia. It was really important that the brand helped people feel less alone, help them feel supported. And they told us that they wanted the website to be in everyday language, to have practical, localized information to help people with dementia and carers live well with dementia. So this is one thing that we haven't really achieved for the website yet, because trying to keep local information easy to find, searchable, and up to date is a really big task. They wanted it to be trustworthy, up to date, and comprehensive. It was very important that it included stories and perspectives of people with dementia and carers, and account for different circumstances and preferences for information. It also needed to be easy to navigate with fonts and layout. So we thought we had built a pretty good website, and then we did some user testing, and it turned out we hadn't. So my honours student last year, Jackie Zheng, we had a small sample of people living with dementia and carers, and through Zoom, he showed participants the website. They screen shared, and we recorded what they were doing and kind of rated, I guess, how they navigated the website. For carers, we also used the Think Aloud protocol, but that was more difficult for people with dementia, so we didn't kind of push that. And after the first 4 users, we realized that the website, while it had useful content, was really hard to navigate despite our best intentions. And we made major changes to how it was structured, to how it was laid out, and to some of the functions of the website. We made it easier for them to use. So this is some of what Jackie learned in his paper on what people wanted from the website. So it needed to have simple, clear, and direct language. It needed to have empowering, positive language, and use relatable, representative, and warm images, which is similar to all that co-design stuff. But the second group of different participants told us this again. And again, it needed to have tailored content. And another thing it needed to have is, it was really important that it presented the our team credentials to enhance credibility and perceived usefulness of the content. They wanted to know we were trustworthy. Here are things that we learned about functionality. So we needed to implement functions that don't require memory, numerous complex steps, or additional setup. So it really needed to be clear what people needed to do. And we had tried to put a toolkit in the website, and it was too complicated. People wanted a way of saving information. The way we had set up for them to save information just didn't work for them. So we really needed functions that made it like searching easier. So a search icon wasn't very good in the first place. The way we searched the website search didn't work very well. And even the way that we had set up for people to be able to print or share information was not clear enough the first time. So we had to rethink how we did those things in our website. It was really important that people were able to print their information. It's quite particular, I think, to this demographic. So we had to make sure that people had minimum number of clicks to get to the information they wanted. And we really needed to make sure that the things that they had to click were really clear, because sometimes we thought that they would click on something and they didn't know they would click it. The other thing is that we learned is that people with dementia and older carers, they weren't good at scrolling beneath the fold. So they just saw us on the top of the screen and they didn't realize they had to scroll down. And we had to work on the scroll bar to make it really clear that they needed to scroll down. And we had to design a website so it was clear there was information below the fold, which is really kind of interesting for us. So yeah. And then we also had to really make it really clear what things, I guess, what elements were where. So really clear prompts and cues and visual aids about what to click and where they'll go when they'll click, and how to get people to go back and forth. So the website has a menu, but people found it hard to get back to the main menu. And because sometimes people's memories were poor, they didn't know how to get back to the thing that they wanted to find beforehand. So we had to try and figure out how to scaffold like the memories of people, if that makes sense, so that they could find their way back to the start easily. So we tried to use fonts, designs, even color use to try and make it really clear what things they should look at for navigation. Quickly showing you that we did some very simple ratings of usability, and the orange is for the first version of the website when we tested it with 4 people and it was terrible. And then, is that right? Yes. And then the purple is for the second version and basically gets more usable, even though it's a small sample afterwards. And I just want to talk about how difficult it is to balance co-designing this information. So we had a whole list of things that people said we should put on their website, but also we needed simple navigation. So that was a tricky balance. We had to be positive, but when we were too positive, people said that wasn't realistic. So we needed to be realistic and tell it like it was. It was a big balance. It was also a big balance, I think, trying to balance 5 countries and 3 stakeholder groups. And I think many of you will have seen the website already, but I'm just going to show you some screenshots of it. So this is the Polish website. This is the French Canada, stories of people with dementia and carers. And this is the Australian website, where we've tried to use action-oriented language, no jargon, and you can see kind of the rehabilitative focus. I think in the last few minutes of my formal presentation, I'm going to show you a bit how we've been campaigning the website. So you can build a website, people aren't going to go to it. You have to drive people to your website. So our Polish colleagues actually realized that stigma was really high in Poland, in Wrocław, where they work. And so they worked with the council to just raise the profile of dementia. And so you can see our Forward with Dementia brand on local buses. They had a memory bus that did memory testing. They managed to light their town hall up purple for Dementia Awareness Month. And they had big public concerts like this one around the brand for dementia. Most of the other countries, our campaigns were, I guess, less flashy, less public, and more targeted at people with dementia, carers, and health and social care practitioners. So the French, here's our Canadian team, you know, running local booths at conferences and running public strategies, and that's what we've been doing here in Australia. We haven't had any physical events, we've had lots of virtual events. So people have been asking, well, how are you evaluating this? It's really hard to evaluate this kind of messy, complex intervention. We have taken the approach that each country is a case. So we're doing 5 case studies that we're going to compare. Obviously, within each case, we'll be looking at website metrics. We've been surveying people who've come to the website. They don't like doing the surveys, to be honest. And we've also been interviewing people with dementia, carers, health and social care practitioners, and key stakeholders. And obviously, I don't have that evaluation data yet, but I think it's been reasonably positive. And the website, I guess, is slowly getting traction and being linked to by other key resources. So I think to finish, I'm not going to show you the pathway, but what I'm going to talk about, I guess, is that that we know that there's lots of different people, groups, who support people after diagnosis. There's primary care, GPs and practice nurses, hopefully, and the PHNs who support them. There's secondary care, so the specialists in hospitals, wonderful nurses and doctors who work there, and allied health teams as well. There's private medical care, and then there's the aged care and other social services, and that these services are funded as silos. Sometimes they push each other, I guess, you know, they don't compete, they compete for resources. I don't think that's the issue, is that they, you know, where they're trying to push people out of their service into someone else's service because their service is stretched, and that the models of clinicians talking to each other and data talking to each other within those systems aren't very good. And I'm not going to talk about the pathway, but that's what the pathway is starting to think about. So I've talked a lot.
Thank you very much, Li-Fei. We now have some time for Q&A, which I believe Alex is going to moderate. So if you have any questions, please submit them in the chat now, or if you'd like, you could turn on your camera and microphone and ask a question in person.
Okay, well, thank you so much, Li-Fei. What an amazing journey, and really just amazing amount of work, and the collaboration with all these international partners must be just super challenging, but also super inspiring, I imagine, taking this kind of global.
I love them all now, but I didn't love them about 6 months ago.
Yeah. Okay, well, just sort of looking through some of the comments and questions that have been posted so far, please do feel free to start posting questions here for Li-Fei. I might just start with a question here from Shane Dennison, who's asking, what was the sample size for the Australian surveys?
I've got, that's my slide, isn't it? We probably had, let me open my slides, which I've now closed, and tell you. Ask me another question while I find my slide.
Well, maybe while you find your slide, I'm just going to sort of ask you to comment on your views. You've said that in some countries there's better access, and in other countries poorer access to post-diagnostic support services, and we are probably somewhere in the middle. What are your views on the extent to which people living in countries with better access, like us, can do things in the online space, or have the responsibility for doing things for people in other countries that, for example, might not have for a long time access to sort of publicly funded support services? Do you have any thoughts on how?
Yeah, I can answer that. Let me tell you this first. We had 28 people with dementia, 58 carers, and 99 healthcare professionals in the Australian surveys. Yeah.
Okay, thank you.
on the question of how we support people in countries that don't have services, I mean, that's the reason that we ended up with a website, because we were working with WHO and ADI, Alzheimer's Disease International, as partners, and they really stressed that, like, if it was to be useful, we needed to make a cheap intervention that other people could use. And so as we've been presenting this, so we pre-record our presentations for ADI this week, but the idea is that now that we've kind of got this base resource that other countries could take it and translate it and adapt it. They need to translate and adapt, but I think we've got them, and they might need to test the messaging, but at least it works in those 5 countries, and that's a resource that other countries could have. And we also have, you know, campaign templates and campaign materials, and we would support them to then do the advocacy work that is part of the campaign. So part of the campaigning work is you know, getting people to use your website, and we've been going out to, in Australia, for example, we've had a strong push to work with diagnosticians. So we've, you know, done webinars for memory clinics. We've done, you know, gone and spoken to neurologists and done presentations for this and put things in newsletters of geriatricians. Does that make sense? So you've got to kind of figure out who behavior you want to change. But we've also been advocating publicly, I guess, for more post-diagnostic support, and that's part of the whole campaign. And I think that, well, we hope that this resource will help other countries do this kind of work faster, if that makes sense.
Right, great. Thanks, Li-Fei. Questions keep pouring in. The next question here from Melinda Curtis is, how do you see the volunteer sector engaging with the funded pathway model? Is there a role for volunteers?
Yeah, so I didn't get to talk about pathway because obviously I'm too ambitious in how much I wanted to share with you today, but volunteer organizations, like, they're part of local services. So in my mind, ideally, PHNs have funding at the moment to develop a local dementia pathway for GPs, and their local pathway should include a list of local services. I already said that, you know, people with dementia want a list of local services, but we realized that even though we wanted to do it, that it was impossible, kind of like, for a national website to really have a good list of local services, and that someone local needed to make that list. And because PHNs, I guess, are local, like, that's how that structure's been set up, and they have a bit of funding, I think they're in a reasonable position to have a list of local services. So while we've made this generic pathway of you know, how specialists, Dementia Australia, Dementia Services Australia, GPs might work together, you know, and the role of the person with dementia and carer in that decision making, that pathway gets localized, and the volunteer organizations would be part of that localization. But within our pathway, it was impossible to call out those little things that don't fit within the system. Does that make sense? Because that's the thing, that everywhere is different. So we had to try and make a model that had the big structures in place and then had room for the smaller structures, and then we acknowledge that they need to be tailored, like, for and implemented locally.
Yeah, that must be super challenging, but I think a great way forward to think about creating that overall structure that then can be tailored to specific localities. I've got a question here from Anita, wants to know whether people with younger onset dementia were represented in the study, and whether you think that they would, you know, could get more specific information related to the needs of people with younger onset dementia.
Yeah, we had probably overrepresentation relative to prevalence of younger people in both the foundational research, so the surveys and focus groups, and in the co-design groups. So I think in the co-design, from memory, we had 6 people with dementia, and 3 of them had younger onset dementia. Don't quote me on that because I'm just doing it from memory, but that's my memory of it. I think that a lot of the base information about dementia and rehabilitation is applicable irrespective of whether you have younger onset or later onset dementia. I think that some of the social issues are very different and the services are completely different. And so we haven't done it yet, but it's on our list that we would love to have kind of particular information specific for people of younger onset dementia on forward of dementia, and lots of other groups as well, like people living alone, and we haven't got as good information on driving. There's a whole lot of things that we could add to it and improve still. And we're slowly chipping away, keep writing stuff.
Now, Michelle Ferris comments on the team from Dementia Australia that provides post-diagnostic support and wonders what you think would bridge the gap between the clinician who provides the diagnosis and getting them to the support specialists who facilitate this program. How can we encourage the person to seek support from Dementia Australia?
Yeah, so this is a question that we've been thinking about. So we know that the model where there's a Dementia Australia person at the diagnostic clinic increases take up of the referral. So on the day they're diagnosed or on their follow-up interview, if there's someone like from Dementia Australia there who they meet, and it's a very I'm trying to think of them as different levels of referral. So it's a really warm referral where they meet the Dementia Australia person who talks to them about what services are available. We know that works, but it's a really expensive model, right? Then there's kind of the intermediate referral where the memory clinic social worker or clinician kind of says, our local Dementia Australia worker is so-and-so, you can, they'll give you a ring. And there's some dementia advisor models that also do that. So they actually give, with the person's permission, give their phone number. And so the outreach is from the dementia advisor, from the dementia person. Does that make sense? And then the coolest level of referral is that you get a flyer that says, or a letter that says you should ring Dementia Australia. And all the CADMS clinics have that as part of their standard letter, is my understanding, but they get very few kind of take-ups from that. So it feels like the warmer the referral is, like the more people know what they're getting into, and the less they have to explain their story and ask for help, if that makes sense, the more likely they are to uptake it. But even then, lots of people will tell us, lots of the Dementia Australia workers will tell us that people sometimes aren't ready to take the next step. Yeah, so Tracy's saying, yeah, so Tracy does it. So, that model works, I think, really well. It just doesn't happen everywhere, and it's quite expensive to do, I think.
Okay. Thanks, Lithe. Bianca wonders about working with people from COLD communities in the context of co-design, because by the time they are presented and diagnosed, they're often more advanced maybe in their diagnosis than people from non-COLD communities, which obviously makes the process of engaging them in co-design more complicated. Do you have any thoughts about that?
We did not have any COLD representation from people with dementia. We had COLD carers in the co-design, but not people living with dementia from COLD backgrounds. And I think, ideally, I'd love to do it, Bianca, as you know. Practically, it's hard to find people with dementia from, probably for our study, we were going to work with interpreters anyway. We're making an English language website, and we weren't going to be making resources in language. But we would have loved to have more people from COLD, English-speaking people from COLD backgrounds participate in the co-design, and we didn't. I don't think we managed that very well. We might have interviewed some people. Yeah, I think that unless we can decrease stigma in COLD communities and get people diagnosed earlier, it's going to make it really hard for us to be able to find the right people to do co-design with. And for this type of co-design, where we were asking them to do quite a lot, we had to work hard to find people who were willing to do it and had the capacity to kind of give us the feedback we were after.
Okay, there's quite a few other comments and questions. I'm mindful that we're coming up to the hour almost. Maybe I'll just read one more question or issue here from Jennifer, realizing regarding nursing patients with dementia in acute healthcare settings. This can be challenging and disorienting for the patient, for the person with dementia. Inexpensive, simple strategies, for example, painting doors in different colors or pictures on the walls, would be useful to assist in orienting these people. Will there be a campaign to push the implementation of some such simple ideas like this, particularly in hospital wards and in nursing homes? Seems like a simple strategy that is often not used.
Well, I mean, there is a lot of funding for education in aged care. So DTA, headed by Belinda Goodenough, is rolling out education, which would include some of these environmental strategies. I'm less clear about what's happening in hospitals, where we know that non-dementia specialists and non-geriatric teams often know very little about dementia, but I don't know how systematic education is happening in that. I certainly don't know what's happening in Victoria. There was a little bit of work happening here in Sydney, in New South Wales, but I think that's kind of mostly kind of dried up. It's not as intense as it used to be. Yeah.
Great. All right. Well, I think we might be out of time. Jessica, is that right?
Yeah, we've got 2 minutes left, so probably not enough time to answer another question.
There are quite a few comments. I'm not sure whether this can be made available to other attendees with some useful information. But look, we might sort of wrap the discussion there. Clearly, a lot of interest, unsurprisingly. And thank you so much, Li-Fei, for
thanks everyone for coming.
I
hope I gave you more things than what I was. I don't want to repeat my presentation from last week, so.
You can hear this over and over again.
Yeah, everyone, if you'd like to join me in thanking Li-Fei with your clap reactions. Thank you very much. It's been lovely to hear from you. Next fortnight, Colleen Doyle and Marcia Fern will be presenting What Can Volunteering Do for You? Resilience, Befriending and Social Support in the Age of COVID. So please join us next fortnight on Tuesday, the 21st of June at midday. And thank you all for attending our Seminars in Aging program.